And first question is, the audience heard there will be clinical trial of mavacamten in patients with non-obstructive hypertrophic cardiomyopathy. Do you think mavacamten is still effective in those patients?
Okay. That's a very good question. I know that in Korea, from what I've learned, there's a higher percentage of patients who have the non-obstructive form of hypertrophic cardiomyopathy than we see in the United States. There was a phase 2 trial of mavacamten called the Maverick HCM trial that showed that there were some improvements in sort of biomarker changes among patients with non-obstructive hypertrophic cardiomyopathy. It was a dose-finding study, but it did not actually show an improvement in exercise capacity. That was a small study. They have launched a phase 3 study of mavacamten in non-obstructive HCM patients. I think there are people in this room who've actually enrolled patients in that trial already. It's called the Odyssey HCM trial, with a goal enrollment in the next year of 400 patients worldwide to see if mavacamten can be effective, and the primary endpoint will be change in peak VO2.
Okay, the second question is, I don't understand second question. We move third question. Do you think mavacamten is still effective in mid-ventricular obstruction? Most study was done in LV obstruction.
Yeah, a good question. Those patients will be allowed in the Odyssey trial. I think if there is evidence of hypercontractility causing the mid-ventricular obstruction, not an anatomic, but it's really hypercontractility, I think there are reasons to think that it would be beneficial. But again, that still needs further study.
Thank you for your insightful lecture. And I'm Hong-Mi Choi from Bundang University, Seoul National University, Bundang Hospital. And I'd like to ask you about the difference in the different response. Is there any difference to response in according to the genetic status of the enrolled patients in the Explorer HCM study?
Yeah, that's a good question. As I showed in the patient characteristics, only 20% of patients in Explorer had a pathogenic or likely pathogenic sarcomeric variant as the cause of their hypertrophic cardiomyopathy. It was a pre-specified subgroup that was analyzed, and there did not seem to be a significant difference in response. But again, it was a small percentage of patients who had a pathogenic variant.
Thank you. Because I think that there are some subset of patients who have a genetic mutation in sarcomere. So some patients maybe there are some subset of patients who do not respond to the mavacamten, I think. So I was very wondering about that. Thank you.
I have a question. Is there a difference as in, did you maybe analyze what are the characteristics of the non-responders to mavacamten? Because there were non-responders.
Yes. That's a good question. That analysis is still being done. It's complicated, I think, in order to sort of define what we would say is a clinically relevant lack of response. You know, is it just with the primary endpoint, or should it be the primary endpoint as well? And as you can see, the majority of patients did have an improvement in biomarkers. That a BNP fell dramatically. So how do we define that? That analysis is still being done, but that's a very relevant question.
And when you use mavacamten, one of the major side effects is, though it's rare, it's a decrease in the ejection fraction. But decrease in ejection fraction HCM usually means that they are progressing to a very bad burned out stage. So in these patients on mavacamten, how can we differentiate patients who are burning out and getting worse and patients who are just getting worse systolic function because of the mavacamten. I think that is one of that will be a problem in the future. Perhaps.
Yes. So fortunately, the rate of that happening is very low. I failed to mention in my talk that in the Explorer-CN trial, 0 patients on mavacamten had a reduction in their left ventricular ejection fraction below 50%. So it's fortunately low. I think the major way to differentiate it is the temporary drug discontinuation. There have been, in one of the studies, I think 1 patient who did not have complete recovery of their ejection fraction, whether it was an effect of mavacamten or something else. But almost all of the other patients, especially in the Explorer, the main Explorer study, had recovery of their ejection fraction within 4 weeks.
And what happened to that particular patient?
The one patient who,
Right.
I think it was a Valor patient who had to have permanent drug discontinuation because at 4 weeks they still had a reduced ejection fraction of less than 50. I don't know longer term if there
Right.
was later recovery. It was just a slow recovery. I don't know what's happened to that one patient.
It's a pity they didn't have an Explorer Korean trial, just an Explorer China trial.
Yeah, and
we could have
there-
done much better actually.
There is
Just
actually,
joking.
there's not, it's not called Explorer. There's a Horizon trial in Japan being launched, also with a low starting dose of 2.5 milligrams daily. I think it's actually going to be a smaller study
Right.
than Explorer-CN. So, but I think, adding all the results together, it will be interesting to see if the results look very similar to Explorer or in some way different. I think it's reassuring in
Right.
the CN trial. It looked very, very similar to Explorer, really, for all the measures that they had.
We do have more panel members in the audience, so any member of our audience are free to ask questions if he wants. Dr. Jo, we have Dr. Jo Dong-hyuk.
Thank you for your wonderful lecture. When I talk about mavacamten with my patients, they are very curious about how long, because it's very expensive. So in your practice, so if you start this medication, you continue. And do you think is it forever?
Yes. I'm glad you're having these discussions with your patients. Especially because it's a new medicine. Many patients, are unfamiliar with it, don't understand the requirements of monitoring. One thing I always tell our patients that we're talking about it is that it will take a few months to see the full effect of mavacamten because the dose really cannot be increased, and some patients may require raising the dose to see the full effect to 10 milligrams and even 15 milligrams, which is the highest daily dose. So I always talk to the patients to say, you're not going to have an immediate effect or even within the first 1 or 2 months. If you are patient, yes, we will get to the right dose that will reduce your symptoms and reduce your outflow tract gradient, but it may be 3, 4, 5 months. But unfortunately, it is a drug that is, I guess not unfortunately, it is reversible. It's not a permanent effect. And as seen in the echocardiogram of the patient who had transient left ventricular dysfunction, off the drug, the patients will have return of their outflow tract gradient. And the interesting thing is once patients know what it feels like to have minimal symptoms, when the symptoms come back, they feel it's really even worse than it was before they started the drug. So it's sort of like when you don't have pain in your knee anymore and it comes back, it suddenly feels much worse than you remember it ever being. But I think I've seen that in some patients as well, where they temporarily discontinue it and then they come back, their ejection fraction is high, they have a high outflow tract gradient, and now they, quote, feel worse than they did even, before starting.
Thank you.
But that may be a subjective response, not really that it's something, truly different.
I hope it's not like something like an addiction or something.
There's no withdrawal. There's no withdrawal symptoms.
Any more questions? We have some more questions from online, many actually. The one that Dr. Joe just referred to is actually in accordance to Dr. Joe's question. The question is, how does the LVMI, do you think, in your mind, decrease? How did they
did it happen?
decrease?
Yeah.
And if that is actually true, will there be a permanent reduction in myocardial mass, and we may be able to stop it somewhere down the line?
Yeah.
Is that possible?
Very,
the mechanism.
very important questions. So, number one, I would say it's a great opportunity for your group of imaging experts to evaluate it, particularly with MRI long-term. You can see in the MRI sub-study, it was only 18 patients treated with mavacamten. That's very small to make any conclusions about, you know, the effect long-term on LV mass. I think that my explanation for why there was a reduction in left ventricular mass index is that there was probably some regression of the secondary hypertrophy when the outflow tract obstruction was relieved. That has been seen after myectomy, for example, that the LV mass index goes down, even not accounting for the myectomy portion, but in resected areas, there is less thickness, and there's probably a secondary compensatory hypertrophy in patients that have a very high outflow tract obstruction that regresses over time. The question of whether patients perhaps who have hypertrophic cardiomyopathy and have no symptoms, they would have some, you know, almost a preventive effect of further progression is really I think a sort of lofty question, because obviously this drug has some potential adverse side effects. There was an experiment in a genetic mouse model of hypertrophic cardiomyopathy where the fetuses were dosed with mavacamten, and it actually prevented the phenotypic expression of hypertrophic cardiomyopathy in a mouse, not in a human.
In a mouse.
In a mouse. But I think to me, it really raises the question, because I think we used to think that the hypertrophy led to the hypercontractility, but it actually may be the reverse, that the hypercontractility in the sarcomere actually leads to the hypertrophy.
So, we have a lot of questions are coming up online. So I don't understand this question quite well, but it's asking, what do you think applying these target medication to genetic variants with overt heart failure or arrhythmia? I think it's asking to what kind of genetic variants what kind of genetic variants would be more like responsive to these drugs? I think that's the doctor.
It's hard to extend it beyond hypertrophic cardiomyopathy. The sort of phenotype that seems to benefit thus far are those with hypercontractility and some outflow tract obstruction. Whether it may, I think the question is really, could these results have implications for heart failure with preserved ejection fraction? And the effect in non-obstructive hypertrophic cardiomyopathy may give us some indications, but as you all know, HFpEF, or heart failure with preserved ejection fraction, it's been very hard to identify a treatment that was really effective until recently, and whether cardiac myosin inhibitors will have any effect there is still unknown. So my guess is the question was whether, for example, HFpEF might benefit from something like that.
So, and the next question, there's two questions. I think they have good points. A doctor asks, I heard that mavacamten has a long half-life similar with digoxin. So while using mavacamten, if the LVEF was reduced to below 50%, how much did it take to come back when it was stopped?
Yeah, so the half-life is about 9 days, but in poor metabolizers, it may be out to 20-some days. And that's why in the recommended dose discontinuation or drug discontinuation is 4 weeks to allow to see full recovery. There was another question about what do you do in someone who has symptomatic reduction in their left ventricular ejection fraction before 4 weeks? Is there any drug to use to try to, stabilize the patient?
So antagonize the
or to
effect.
reverse it. In the clinical trial anyway, the protocol suggested, didn't mandate, that if a patient did develop very severe symptomatic systolic heart failure, that use of dobutamine could be a temporizing measure. I don't know of any data to show whether that still has a benefit or an effect, but fortunately, the few patients I've seen that have had the transient reduction in systolic function have not had any severe heart failure symptoms.
So the decrease in ejection fraction came back like very rapidly, like
Fairly
about
rapidly. Like
2 or
the
3
most
days?
recent patient that I had is actually a woman who is in the Maverick study, the non-obstructive HCM trial. She's in the long-term extension study, so she's being provided open-label mavacamten. She developed atrial fibrillation and was symptomatic more from the atrial fibrillation, but in that setting, her ejection fraction fell to around 40%. She underwent cardioversion, is now on a rhythm-controlling drug. She came back 4 weeks later after cardioversion. Her ejection fraction is, back to 65%. But it does bring up the point that I think the ones, and we talked about this before the meeting, is that the one situation where it's really recommended to look for evidence of systolic dysfunction is in a patient who has recurrence of atrial fibrillation. For some reason, that really seems to increase the risk of systolic dysfunction.
And in patients with stress-induced cardiomyopathy, the myocardium get edema when their ejection fraction recovery. During recovery, is there any edema of is there any more edematous change during recovery?
That's a very interesting question. I don't know of any cardiac MRI that's been done in the transient left ventricular systolic dysfunction phase. That's a very interesting question.
And I think this is going to be the last question. A doctor asks, given the action mechanisms of mavacamten, so when inhibiting active myosin bindings, can there be a side effect of mavacamten in skeletal muscles, which might lead to systemic symptoms such as fatigue or myalgia? I think that's a good point that he's asking.
Yes.
She's asking.
And at the very beginning in phase 1 and phase 2, there were some, theoretical or hypothetical concerns about it. But because it targets only cardiac myosin, it's very specific. And in the safety events of the clinical trial, there were no differences between the mavacamten or the placebo-treated patients.
I think the discussion can just go on for just throughout the night, but I think we'll have to let Dr. Wang go. He will be leaving the country early tomorrow morning. Thank you, Dr. Wang.
Thank you very much, Dr. Lee.